Hello and welcome to Critical Care MD. My name is Dr. Vikas Koparapu and I am a physician in pulmonary and critical care medicine. My goal with Critical Care MD lectures is to help you understand fundamental concepts of critical care medicine so that you are better prepared for your ICU rotation and you are more comfortable in caring for the critically ill patients. Today's topic is sedation in ICU. Let's start with some practice questions. Case number 1. Here we have a 75-year-old female who was admitted to floor for severe hip pain in setting of a hip fracture. She developed delirium and also needed increasing doses of opioids for pain control on the floor. At shift change, the nurse noted that patient was obtended and there was vomitus around her mouth. Patient was urgently transferred to ICU and intubated for airway protection. Vitals after intubation are, as you can see on the screen, heart rate 55, blood pressure 106 by 55. Patient appears very uncomfortable, tachypneic, agitated, and even trying to reach the endotracheal tube. Nurse is asking you to place sedation orders. What agent would you pick? A 46-year-old patient was intubated for respiratory failure in setting of ARDS. She was noted to be very agitated, hypertensive, tachypneic, tachycardic, and trying to reach the ET tube. So propofol dose was increased and she was started on fentanyl infusion. Next day in the morning, you notice that patient is minimally responsive. Let's say you do a deep sternal rub or painful interventions and she barely opens eyes. All the features of agitation like tachycardia, tachypnea, hypertension, increased motor activity, all of those have resolved. What changes would you make to her sedation? Case number 3. We have an 82-year-old female who was transferred to ICU for severe respiratory failure in setting of pneumonia. She was placed on non-invasive ventilation and her respiratory distress has resolved and oxygen levels have significantly improved. However, patient is very anxious, appears uncomfortable with the NIV mask and intermittently trying to remove it. Code status is DNR and DNI. She has normal heart rate and blood pressure. What agent would you pick to sedate this patient? Last case, we have an 85-year-old male with CKD stage 4 who is admitted for complete heart block in setting of unintentional beta blocker overdose. Transvenous pacemaker was placed and patient's condition stabilized. Let's say this morning you are assessing the patient and patient's intrinsic heart rate is more than what the pacer was set at and QTC is normal. However, patient is noted to be delirious. He is intermittently trying to get out of the bed, attempts to pull out the pacemaker, and his code status is DNI. What agent would you pick to sedate this patient? Think about what option you would pick for each of these questions, and we will discuss answers at the end of this video. Here are the objectives for today's discussion. We will start with a systematic approach to an agitated patient, and then we will move on to sedation. We will discuss it under these three headings: initiation, maintenance, and weaning. The goal of sedation is to control agitation, and sedation is only one of the several tools available to achieve this goal. So, before going into the discussion about sedatives, let's understand the importance of agitation. Here is the definition of agitation according to a textbook of critical care medicine. Basically, what it means is mental tension leading to excessive, unnecessary, and repetitive motor activity, which can be potentially harmful. ICU is a unique environment where distress and agitation are very common. For example, they're usually very ill with severely deranged physiology. They're also frequently hooked up to different lines and tubes like endotracheal tube, chest tube, Foley catheter, etc. Due to factors like these, patients' ability to communicate and mobilize are severely restricted. Not only that, they frequently undergo painful procedures and they're regularly disturbed by loud alarms, vital checks, and lab draws. So it's very hard to get much rest or sleep in the ICU. Uncontrolled agitation can have several harmful effects. For example, the high sympathetic tone and metabolic demand associated with agitation can really disrupt the supply demand balance, especially in a patient with circulatory shock. For patients on the ventilator, agitation can lead to ventilator dysynchrony, increased ventilator pressures, which can lead to hypoxia and barotrauma. Severe agitation does not only lead to interference with treatment but can also be associated with harm to patient and staff. One study reported that 1 in every 4 patients who undergo stressful experience in ICU report symptoms of PTSD 4 years down the road. It is very important to develop a systematic approach to an agitated patient. It always begins with identification and treatment of the underlying cause. Interventions specifically to treat agitation include non pharmacological interventions, which are the safer and simpler methods, and finally, sedation. Pharmacologic sedation must be considered only when above methods fail or during urgent situations. As we have seen, ICU is a unique environment where factors leading to distress are common. Distress can be in the form of fear and anxiety, pain, shortness of breath, withdrawal from drug or alcohol, and delirium. Keep in mind that one patient may be experiencing all of these or multiple of these at the same time. Common example would be someone on the ventilator, which is probably the most common reason for sedation in ICU. Pain is very common in ICU. More than 50% of patients admitted to ICU report experiencing pain and discomfort. Interestingly, pain is reported with equal incidence in both medical and surgical ICUs. Patients in ICU don't need a reason to be in pain. Let me explain. Surveys conducted in ICU patients have shown that they experience pain in three different settings. First is from expected reasons like trauma, medical and surgical procedures. Second is from unexpected reasons. For example, patients have reported significant pain during interventions like being turned in bed, suctioning via the endotracheal tube, etc. These are generally not expected to cause pain. Finally, significant proportion of patients also report pain even when resting. This kind of pain is very similar to pain people experience during a flu-like illness, and inflammatory cytokines are implicated in the causation of this kind of pain. Once a cause is identified, every effort must be made to treat it. For example, if the cause of pain is bone fracture, it needs to be stabilized or immobilized. If the cause of shortness of breath is pneumonia, it needs to be treated with antibiotics. If the cause is PE, it needs to be treated with anticoagulation, and so on. If the cause of agitation is alcohol withdrawal, appropriate agent like benzodiazepine must be used. Delirium can be from several different causes, each of which must be looked into and treated. Finally, simple interventions like frequent communication and reassurance as appropriate can reduce fear and anxiety. Don't forget the importance of non pharmacologic interventions like frequent communication, regular caregiver visits, establishing a normal sleep wake pattern. Additional interventions include cognitive behavioral therapy like music therapy, guided imagery, relaxation therapy, early mobilization or consultation to physical therapy, and providing visual and auditory aids. These simple interventions are effective and backed by evidence. For example, studies have shown that interventions like verbal comforting reassurance, music therapy, etc., lead to positive outcomes like increase in ventilator free days, decreased length of stay, reduction in incidence of delirium, and reduction in sedative use, etc. Physical restraint should be really the last resort. Even after using sedation, if patient is still agitated or if it's an emergent situation, physical restraint must be considered. I just included here because it is still a non-pharmacologic intervention, but it must be the last resort. Finally, we can talk about sedation. Keep in mind that though I have listed these in a stepwise fashion, often multiple of these interventions need to be happening at the same time. For example, let's say we have an elderly patient who is admitted for hip fracture and has hyperactive delirium. Interventions like consulting orthopedics, Tylenol or acetaminophen for pain control, delirium precautions, and sometimes using sedation, all of these need to be happening simultaneously to best control agitation. There is no standard definition for a sedative, but generally speaking, it is a medication that treats anxiety. It also has additional effect of inducing a sleep-like state or depressed level of consciousness, especially at high doses. Finally, it's typically used intravenously. There are some oral agents available as well which have sedative effect, but we don't rely on them in ICU because of their unpredictable action compared to an intravenous medication which usually has a fast onset of action and is easily titratable. Depending on the agent, a sedative may have additional properties which gives that particular agent unique advantages compared to others. For example, a sedative may also have amnestic properties, for example, benzodiazepines. It may have analgesic properties, for example, opioids. It may have muscle relaxation property, for example, propofol. Finally, it can also have anticonvulsant property, for example, propofol and benzodiazepines. An ideal sedative must have the following properties. It must be safe, particularly, it should not cause cardiorespiratory suppression even at high doses. It must have a rapid onset of action. It must be easily titratable. It should have rapid clearance so that once we turn it off, patient should rapidly wake up. Metabolism should not be affected by renal or hepatic dysfunction, which makes dosing easy. It must be universally available. It must be cheap and it must be well studied, especially in the ICU. Guess what? An ideal sedative does not exist. And that is why we have so many different options. Each agent has its own strengths and weaknesses, and it's important to understand those properties so that we can pick the right agent for a given situation. Think of sedation as having three different phases: induction, maintenance, and weaning. Here are some important considerations for each of those phases. For induction, it is important to know the key properties of the drug, especially the rapidity of onset of action and potency, and benefit and risk of each of those agents. Maintenance can be done via intermittent bolus dosing or infusion. It is important to pick a target to which sedation must be titrated. Sedation is generally interrupted every day in the morning to allow for neuro exam of the patient and to also further fine tune the sedation dosing. During weaning, important to keep in mind that longer infusion times are associated with drug accumulation and delayed recovery after turning off the sedation. This is true even for drugs which are otherwise considered short acting. Withdrawal is also common, especially when higher doses are used for a long time, particularly with short acting agents. We will discuss more details of each of these sections in the next slides. Let's start with understanding the key properties, benefits, and risks of individual agents. Propofol is a highly lipophilic agent that quickly crosses blood-brain barrier and has a rapid onset of action. It is prepared as a lipid emulsion and is easily identifiable by its characteristic milky white appearance. Mechanism of action is by stimulation of central GABA receptors. Key properties of propofol include it is a very potent sedative, has a quick onset of action, and is rapidly cleared. No dosage adjustments are needed in hepatic and renal impairment. Additional actions of propofol include amnesia and anticonvulsant properties. Keep in mind that it does not provide analgesia. Main risks of propofol use are cardiopulmonary compromise, meaning hypotension, bradycardia, and suppression of the respiratory drive. Hypertriglyceridemia and pancreatitis are also reported. Finally, propofol infusion syndrome, which we will discuss in a later slide. Here are some important numbers to know for propofol. Onset of action is within 2 minutes. Maintenance dosing is between 5 to 50 micrograms per kilogram per minute, and duration of action is under 10 minutes. Usually, propofol boluses are avoided in ICU because they're associated with bradycardia and hypotension. Propofol infusion syndrome is a rare and dangerous side effect associated with propofol use. It is manifested by bradycardia, severe hypotension, hyperlipidemia, rhabdomyolysis, AKI, and metabolic acidosis. Risk factors: it is generally seen when high doses are used for a long time. If you stick to the recommended dosing of less than 50 microgram per kilogram per minute, then it would be very, very rare to see this syndrome. Additional risk factors are young age, critical illness. Of course, in ICU, all patients are critically ill. Catecholamine infusion like epinephrine and steroid use. Lab features of propofol infusion syndrome are high triglyceride levels, lactic acidosis, elevated creatinine kinase, and myoglobin. Sometimes triglycerides are obtained something like every other day to monitor for propofol infusion syndrome, but the evidence for that is not great. Mortality can be very high depending on what study you pick, up to 66%. Treatment is mainly supportive. You do appropriate volume resuscitation, use vasopressors to maintain the hemodynamics, etc. Opioids act via activation of central opioid receptors. In addition to being sedatives, they are excellent analgesics. Main risk with opioid use is cardiopulmonary compromise, especially suppression of the respiratory drive. There are three main agents available. Their properties are shown on the screen. Note that fentanyl has a rapid onset of action and a very short duration of action, both of which make it an ideal choice. Fentanyl has several advantages compared to other opioids. It is a very potent sedative, has a quick onset of action, and is rapidly cleared. Its use is associated with less hypotension and bradycardia due to less risk for histamine release. There is no accumulation of toxic metabolites in setting of renal or hepatic impairment, therefore dosage adjustment is not required compared to other agents like morphine. Ketamine is an NMDA receptor antagonist. It has quick onset, is rapidly cleared, and generally does not cause cardiorespiratory suppression. In addition to being sedative, it also has analgesic and bronchodilator properties. Despite these advantages, ketamine is not a popular choice in ICU because it has several disadvantages as well. For example, it causes increased sympathetic drive, which leads to tachycardia, hypertension, and increased myocardial demand. It is associated with unpleasant sensations like hypersalivation, nausea, and vomiting. It can also cause psychiatric effects like hallucinations and delirium. Dexmedetomidine or Presidex acts via stimulation of central alpha 2 receptors. Its key properties are it has a relatively slow onset of action and it is not very potent. Despite these shortcomings, Presidex is a very popular agent in ICU because it has several benefits. It provides analgesic effects. It does not suppress the respiratory drive. Therefore, patients can be extubated while on Presidex, or it can also be used in patients who are not on the ventilator. It is less likely to cause delirium, especially compared to benzodiazepines. In fact, Presidex is frequently used to treat hyperactive delirium. Compared to benzodiazepines, use of Presidex has been shown to be associated with shorter duration of mechanical ventilation. The biggest side effect of Presidex is bradycardia. It is probably the most common reason why Presidex is discontinued or not used. Here are the important numbers to know for Presidex. As you can see, it has a relatively slow onset of action, especially compared to agents like fentanyl or propofol, and relatively longer duration of action as well. Benzodiazepines or benzos act via activation of GABA receptors. There are three main agents. Versed is very popular because similar to fentanyl, it has very quick onset of action and short duration of action. Ativan is another popular agent. It is slower compared to Versed. We rarely use diazepam in the ICU. Main benefit of benzodiazepines is that they are potent and provide additional effects like amnesia and anticonvulsant effects. However, they do come with risks, cardiopulmonary compromise, but more importantly, benzodiazepines are notorious to cause drug accumulation, delayed clearance, and associated encephalopathy and delirium, especially when higher doses are used for a longer time. Benzodiazepines have also been shown to prolong mechanical ventilation, and due to encephalopathy, patients usually end up getting workup like unnecessary head CT scans. For these reasons, benzodiazepines are among the least favored agents for sedation in ICU. However, they do have their place. Certain indications like alcohol withdrawal or seizures, benzos are actually preferred agents. Haloperidol or Haldol is an antipsychotic agent that blocks dopamine receptors. Its key property is it has a relatively rapid onset of action but is not a potent sedative. Main benefit is it does not cause cardiorespiratory suppression. Main side effect with Haldol is it causes QTC prolongation and associated arrhythmias, can also cause extrapyramidal movement disorders. Pertinent numbers for Haldol are shown on the screen. It has slightly slower onset of action compared to traditional agents like fentanyl and propofol, but not too bad. Barbiturates are older agents with several disadvantages and they are generally not used in ICU except in rare situations like select cases of alcohol withdrawal or refractory status epilepticus despite multiple first line or second line agents. Etomidate works via activation of GABA receptors. Its key properties are it has a rapid onset of action, it is a potent sedative, and is rapidly cleared. Main advantage is it does not cause cardiorespiratory suppression. While it may look like an attractive agent, unfortunately, studies have shown that with continuous infusion of etomidate, there is risk of adrenal suppression and even increased mortality. So its use is pretty much restricted to bolus dosing for rapid sequence intubation. Pertinent numbers for etomidate are shown on the screen. I know that was a lot of information. It will make sense once you start seeing these agents being used in ICU. For a beginner level, I would recommend focusing on these three agents. These are probably the most commonly used sedatives in ICU. With that background, let's understand the three phases of sedation. The goal of induction is to achieve sedation as quickly and as safely as possible. Here is the most important principle to keep in mind. We got to pick the most appropriate agent that our patient will tolerate. An agent may be very good, but if our patient has contraindication to it, then it's no good. In order to pick the right agent, we need to understand important properties of the agents we talked about. High potency and rapid onset of action would be preferable for an ideal induction agent. We also need to know additional properties of the agent. For example, if a patient was intubated for airway protection in setting of seizures, propofol would be preferable over something like Presidex or fentanyl. Finally, we need to understand the risks. If a patient is severely bradycardic, then Presidex is not the agent I would pick. Once sedation is successfully induced, the focus must be maintaining the fine balance between too much sedation and too little sedation. Too much sedation is harmful. It is associated with prolonged mechanical ventilation and all the risks like barotrauma and volutrauma. Prolonged ICU and hospital length of stay, it leads to increased morbidity and costs associated with them. And increased risk for delirium and drug withdrawal are also common with prolonged infusion times. Too little sedation, on the other hand, leads to uncontrolled agitation and all the harmful effects associated with it. So, the goal of maintenance is optimal treatment of agitation while using as low dose of sedation and for as little time as possible. Sedation can be administered via intermittent bolus dosing, but more commonly via continuous infusion. Regardless of the method, it is important to define a target or goal towards which sedation must be titrated. It is important to interrupt sedation every day and let the patient wake up. Let's understand the details of these. It is important to understand how sedated the patient is. There are various scoring systems available, but the ones commonly used are RAS and SAS. Here is the Richmond Agitation Sedation Scale or RAS. 0 is alert, calm, and cooperative. Anything on the positive side indicates increasing levels of agitation, and numbers on the negative side show increasing levels of sedation. Lighter sedation is preferred compared to deeper sedation. Let's say when you're assessing the patient, he is not responding to verbal stimuli, only grimaces or opens eyes to painful stimuli. That gives him a RAS score of -4. In that case, we need to decrease the sedation to bring it to anywhere between 0 to -2. Sedation is generally interrupted every day, an intervention also known as spontaneous awakening trial or sedation vacation. The purpose of doing this is one, it allows good neuro exam of the patient and minimizes neurodiagnostic tests like head CT scans. It also allows minimizing sedation. Generally, when sedation is interrupted and restarted, it allows to use a lower dose. This intervention is generally combined with spontaneous breathing trials in intubated patients. However, there are certain cases where sedation is best not interrupted. For example, if a patient is being treated for status epilepticus, we want to make sure that is adequately controlled before interrupting sedation. Several aspects of maintenance, like titration of sedation towards goal RAS and daily interruptions, are done by ICU nurse. As the underlying disease process is improving and agitation is resolving, it is time to start weaning and discontinuing sedation. There are two important issues to keep in mind during weaning. First is delayed recovery, and second is withdrawal. Higher cumulative doses lead to drug accumulation in the tissues and delayed recovery from sedation. This applies even to short acting agents like fentanyl and propofol, especially when the patient has been on sedation for more than 7 days. The goal of weaning is to allow as rapid recovery from sedation as possible while minimizing the withdrawal effects. Withdrawal symptoms associated with commonly used sedatives are shown on the screen. Usually, these involve sympathomimetic symptoms like anxiety, agitation, tachycardia, hypertension, and restlessness. Treatment includes gradual taper with a long acting agent. Clonidine can be useful in minimizing opioid or Presidex withdrawal symptoms. Now, let's go back to our practice questions and discuss the answers. Case 1 is basically a freshly intubated patient who is agitated and is in pain. Here we need to induce sedation for this patient. In order to pick the right agent for sedation, we need to know the key properties of the drugs. Something which is potent and rapidly acting would be preferable. Among the options, Presidex is not very potent and is not rapidly acting, so we can eliminate that. Second, we need to know additional properties of the drug. Here, patient is in severe pain, so something with analgesic properties would be preferable. Fentanyl is looking like a good choice. Finally, we need to know the risk. Patient is bradycardic, blood pressure seems to be okay, so something that does not drop the heart rate and blood pressure would be preferred. So propofol is not an attractive choice here. That leaves us with fentanyl and Versed. The risk of hemodynamic instability is low with both of these agents, but given fentanyl also has analgesic properties, that would be the right choice here. Case 2, we have an agitated patient on the ventilator. The overnight team did a good job of controlling the agitation. However, when you're assessing the patient in the morning, you notice that she's only opening eyes to painful stimuli. That gives her a RAS score of -4, deep sedation. That's not good either. So the goal here is to lighten sedation. Among the options given, continuing propofol and fentanyl at the same rate is not going to achieve that goal, and she's tolerating propofol and fentanyl okay. So there's no need to replace these with something else. All we have to do is decrease the sedation. So option D would be the right choice. Case 3. Here we have an elderly patient whose respiratory distress has significantly improved with non invasive ventilation. However, she has developed anxiety and agitation which is interfering with her care. So we have to induce sedation here. Remember, the most important goal of induction is to pick the most appropriate agent that the patient would tolerate. Among the options given, phenobarbital is an old agent with a lot of disadvantages. We don't really use it anymore in ICU except for select cases like alcohol withdrawal. Among the other options, she doesn't have a secure airway, so propofol is not a great choice. Between Ativan and Presidex, we have to consider the risks here. Patient's code status is DNR and DNI. So with Ativan, we are not only running the risk of respiratory suppression, but also the risk of delirium in this elderly patient. That makes Presidex the right choice here. Last case. Here we have another elderly patient who also has stage 4 chronic kidney disease and is admitted for complete heart block. He has a pacemaker placed and delirium is again interfering with his care. We need to induce sedation here, which means pick the most appropriate agent that your patient would tolerate. Among the options given, Presidex is not a great choice because of the bradycardia. Avoid morphine in any patient with renal dysfunction. Morphine metabolites accumulate in setting of renal dysfunction, and these metabolites can be neurotoxic. Between Ativan and Haldol, Ativan again runs the risk of worsening delirium and also respiratory suppression. Patient has a do not intubate status. So Haldol is actually the right choice here. Main risk would be QTC prolongation, but the stem of the question tells you QTC is normal. Haldol actually is a decent sedative in cases like this. That concludes today's discussion. I hope you found this video helpful. If you did, please support my channel by clicking on the like and subscribe buttons. Also, share it with someone who you think will benefit from it. Finally, I would love to hear your thoughts. Is there any part of this video that you found particularly helpful? Is there anything I could have added to make this more useful to you? And what topics would you like to see me discuss in the future? Do leave a comment and I will see you in the next video.